All right, here we are, the final video in our series. We've gone deep into the anatomy, the pathways, the physiology of the vestibulocerebellum. But now we take all that knowledge and bring it right where it matters most, to the bedside. We're going to talk about what happens when this incredible system fails. So today, we're zeroing in on a skill that is, and I'm not exaggerating here, absolutely critical. It's about recognizing the clinical syndromes that scream vestibulocerebellar failure. This is where knowing your anatomy isn't just academic, it becomes a life-saving tool. I mean, this is the big one, right? This is the question that keeps us up at night. The patient comes in, they're acutely dizzy, and you're at a crossroads. Is this a benign neuritis, or is it a posterior fossa stroke? The pressure's on, you have to make the call. Get it right, you save a brain, maybe even a life. Get it wrong? Well, the consequences are just devastating. And here's the most important part. You don't have to just sit there waiting for an MRI to tell you what's going on. The clues are right there, literally right in front of you, in the patient's eye movements. You just have to know what you're looking for. Honestly, being able to tell a central cause from a peripheral one right there at the bedside, that's not just a skill, it's a superpower. Okay, let's dive into our first major sign. This is a classic, one of the big ones, downbeat nystagmus, or DBN. The moment you see this, a little alarm should go off in your head and it should be screaming one word, flocculus. So what's actually happening here? Why do the eyes do this? Well, you can think of the flocculus as a brake. It's constantly putting a little bit of inhibitory pressure on the pathways that drive our eyes up. But when those Purkinje cells in the flocculus get damaged, that brake fails. Suddenly there's nothing holding the eyes back, so they start to drift slowly upward. And then, snap, a fast corrective saccade pulls them back down. That downward snap, that's the beat we see. It's pretty cool mechanistically. So when you're examining the patient, there are a few telltale signs to look for. You'll notice this nystagmus actually gets worse when they look to the side, or especially when they look down. But here's a neat trick. Have them focus on your finger as you bring it towards their nose, testing their convergence. A lot of the time, that will dampen the nystagmus or even make it disappear completely. Oh, and sometimes gently extending the neck can make it pop right out. These are the little features that are going to help you absolutely nail this diagnosis. Okay, so you've seen it, you've confirmed it. Now the big question, what's causing it? And this is where things get serious because the list of possibilities is pretty broad. It could be something structural, like a Chiari malformation compressing the flocculus. It could be autoimmune, maybe a paraneoplastic syndrome. It could even be genetic, like spinocerebellar ataxia type 6. Or it might be toxic from medications like lithium or phenytoin. And of course, sometimes we just don't find a specific cause, and it falls into that idiopathic degeneration category. All right, let's shift gears a bit. We're moving just next door from the flocculus, over to the nodulus and the uvula. When these guys go offline, you get a totally different but just as recognizable set of signs. And it all comes back to a concept we've touched on before, that crazy velocity storage mechanism. So first up in this category is something called periodic alternating nystagmus, or PAN. And I've got to say, this is one of the most wild and fascinating things you'll ever see in neurology. You're looking at the patient's eyes, and they have this spontaneous horizontal nystagmus. But here's the thing, it doesn't just stay put. It'll beat to the right for, say, 90 seconds. Then it'll stop for a moment, and then it'll completely reverse and start beating to the left for another 90 seconds. What's going on? It's that velocity storage system, without the nodulus to act as a brake, just swinging back and forth like a giant pendulum. And this is where physiology meets practical treatment in the most beautiful way. A drug called baclofen can essentially step in and do the job that the damaged nodulus can't anymore. It dampens that wild oscillation. So here's the clinical pearl. Giving a trial of baclofen isn't just a treatment, it's a diagnostic test. If you give it and see a dramatic, specific improvement, you've basically just confirmed your diagnosis of nodular failure. How neat is that? Now, the other big one with nodular syndromes is central positional nystagmus, or CPN, and it is so important that you can tell this apart from the much more common benign BPVP. This table is your cheat sheet. Let's run through it. First, direction. CPN is often vertical, especially downbeating, while BPV is that classic torsional, twisting, or horizontal movement. Next up, latency. With CPN, it happens immediately when you put them in the position. There's no delay. BPV, has that classic 2 to 20 second lag. Then think about fatigue. CPN just keeps going and going. It doesn't get tired. BPV, you do it a few times, it fizzles out. And finally, duration. CPN will last as long as they're in that position, over a minute sometimes. BPV is short and sweet, usually less than a minute. So let's be crystal clear on this because it's a huge safety point. If you do a Dix Hallpike and what you see is a nystagmus that is persistent, doesn't get tired, and is beating downwards, you need to stop. Just stop. That is not BPPV. That is a massive red flag for a lesion in the posterior fossa. Your next move is not the Epley maneuver. Your next move is to get an MRI, period. Okay, now for the most urgent scenario we face, the acute vestibular syndrome, that patient who is spinning, sick, and can't stand up. To sort out if it's a dangerous stroke or a benign neuritis, we have an essential bedside tool, the HINTS exam. So HINTS is just an acronym for the 3 parts of the test. You've got H for head impulse, N for nystagmus, and TS for test of skew. That's it. 3 simple things you can do at the bedside that, when you put them all together, are unbelievably powerful. And it all comes down to pattern recognition. The pattern that says, phew, this is probably peripheral, is an abnormal head impulse where you see that little catch-up saccade combined with a nystagmus that only beats in one direction and no skew deviation. The scary pattern, the one that screams central problem, is the opposite. A normal head impulse, a nystagmus that changes direction depending on where they look, and any skew deviation at all. I'm going to say it again because it's so important and a little counterintuitive. In an acutely dizzy patient, a normal head impulse test is a bad sign. It's a red flag. So just how good is this exam? You might be surprised. In the hands of someone who's trained to do it properly, the HINTS exam has a sensitivity of over 96% for picking up a posterior fossa stroke. Let me put that in perspective for you. That is more sensitive than an early MRI in the first 24 to 48 hours. Just think about that for a second. Your own hands and eyes can be more powerful than a multi-million-dollar machine. That's incredible. Okay, so we've made the diagnosis. We've figured out if it's central or peripheral, but what does that actually mean for the patient down the road? Well, it turns out the prognosis and their potential for rehab are worlds apart. You see, a patient with a cerebellar lesion has a really fundamental problem. Their brain's learning software is broken. That key process we have, called long-term depression, that allows the brain to recalibrate and adapt the VOR, it's damaged. And what that means, practically, is that vestibular rehab just isn't going to be as effective for them when it comes to restoring their gaze stability. But take a patient with a peripheral issue, like vestibular neuritis. Their cerebellum is perfectly fine. It's healthy, it's intact, and it is ready to learn. It can fire up all of its adaptation machinery to compensate for the problem out in the ear. And that leads to really, really excellent rehab outcomes. And that, right there, is why getting the diagnosis right from the very beginning, matters so much. So let's just boil this all down to the 3 absolute must-know takeaways. Number 1, you see downbeat nystagmus, you think floccular failure, and you start digging for the underlying cause. Number 2, you see that crazy nystagmus that keeps reversing direction, think nodular failure, and remember that a trial of baclofen is your diagnostic ace in the hole. And number 3, probably the most important one to burn into your memory, a patient with acute, nonstop vertigo who has a normal head impulse test. That is a massive red flag for a stroke. And that brings us to the end of our deep dive. We've covered everything from the basic anatomy right through to these critical clinical signs. It's been a journey, and I just want to say thank you for joining us for this whole series. If you want to explore more about dizziness, vertigo, imbalance, or check out some resources for both clinicians and patients, please come visit us at AustralianDizzinessClinics.com. And hey, if you got something valuable out of this series, we'd really appreciate it if you'd subscribe and leave a rating. It really does help other people find this stuff. So I'll leave you with just one final question to think about. After everything we've gone through, which one of these subtle but absolutely critical eye signs are you now determined you will never ever miss again?